Well, Mount Carmel offers currently 3 procedures for bariatric surgery. The first of these is gastric banding. The second is something called a Roux-en-Y gastric bypass. And the third is a procedure which is newer called a sleeve gastrectomy. The laparoscopically placed adjustable gastric band is a procedure that was widely available and popular in Europe before it became popular in the United States. There are currently 2 adjustable gastric bands available in the United States for implantation. When we implant this device, we encourage patients to look and see if they have a preference as to which type of band they would like to have placed, and if they do not have a preference, then we will decide. It really, however, is irrelevant as you look at the data on these 2 bands with terms of complications and weight loss. The data is essentially equivalent for both bands that are available in the United States. We, however, place both of them based on patient request. The laparoscopic band involves putting a prosthetic device around the proximal stomach to make a smaller and larger gastric pouch. The opening between the smaller and larger gastric pouch can then be changed in size by injecting or removing saline from a port that is located just beneath the skin. The gastric bypass procedure is performed here both laparoscopically and in some situations through an incision. Roux-en-Y gastric bypass is really considered the gold standard operation for bariatric surgery. It's been performed for decades now. There are lots of studies documenting good long-term follow-up and results, and it is really the procedure that all other bariatric surgeries are compared against. The Roux-en-Y gastric bypass procedure involves making a very small pouch out of the part of the stomach just below the esophagus and then attaching a limb of intestine to it. This procedure functions in 2 ways. One, it's what we call restrictive, like the band, in that you have a small gastric pouch and it cannot hold as much, so on eating, somebody becomes full very rapidly. The second part of the gastric bypass's effectiveness is it's also what we call malabsorptive. Since part of the small intestine is bypassed, the amount of calories that are taken in are not as well absorbed, further contributing to the weight loss. The hormonal changes that a gastric bypass induces, which we do not see with the band, are also felt to be critical in areas like inducing early satiety or becoming full very quickly, and also helping with the resolution of diabetes. The gastric sleeve procedure is the newest procedure we have started performing at Mount Carmel for weight loss. It's a procedure we've been performing for several years now, and the gastric sleeve came into being when people were initially trying to figure out how to do laparoscopic bariatric surgeries such as a gastric bypass and an operation called a duodenal switch. What they were doing was doing this procedure in 2 steps. The first step was creating a long tube out of the stomach. What they found, however, was that the vast majority of people did not require any other operations because this simple thing of making a long tube out of the stomach was so effective that no additional procedures were needed. If you look at the data that's currently available, a gastric sleeve is very comparable to a gastric bypass in terms of weight loss, comorbidity resolution, and what it allows the patient to do is eat in a more normal fashion. Some things that we see with gastric bypass, such as dumping syndrome, do not occur because the valve at the bottom of the stomach called the pylorus is intact, and it has good outcomes and essentially equivalent symptom resolution, with perhaps the exception of diabetes, where it still appears that someone who has insulin-dependent diabetes has a higher probability of resolution of this with the performance of a Roux-en-Y gastric bypass. The length of time you remain in the hospital depends on which bariatric procedure you choose. Patients who have a laparoscopic adjustable band placed usually stay in the hospital just overnight. They come in the day of the procedure, the band is placed, that night they get clear liquids to drink, the following day they get full liquids and are discharged home if there are no evidence of problems. Patients who have a laparoscopic Roux-en-Y gastric bypass or a laparoscopic sleeve usually stay in the hospital 2 to 3 days. If we do the procedure through an incision, it usually adds an additional day of hospital stay. What everybody needs to understand is whether a procedure is done laparoscopically or with an incision, it's the same procedure on the inside. All the changes is the way we access the abdominal cavity to perform the operation. However, carrying out a bariatric surgery through an incision rather than laparoscopically usually only adds an additional day of hospital stay. Well, as with any major surgical procedure, there's always a risk of complications. What patients need to understand is that your risk of a major complication or even death from a bariatric surgery is less than your risk of living morbidly obese. The risk of a major medical problem or death from morbid obesity currently is greater than the risk of any of the surgical procedures that we have outlined. As with any major surgical procedure, there's always a risk that is related to anesthesia. There's a risk of pneumonia. There are risks of heart going out of rhythm. Infections are possible. Blood clots in the legs, or those blood clots breaking loose and going to the lungs. These are the complications that are seen with any surgery would do, bariatric or otherwise. Well, the lap band, if you look at the data, has the lowest risk of short-term complications. Because it's a laparoscopic procedure, it's very simple to do. It does not require dividing the intestinal tract or creating an intestinal anastomosis. The risk from injury to the GI tract or gastrointestinal tract leakage is much lower. There is a risk of bleeding, as there is with any operation. More complications are seen with the band in the long term. Since the band is a prosthetic or artificial device placed within the body, there's a risk of that device malfunctioning. The band can slip and need to be repositioned. The balloon can develop a hole. The tubing can break. The port can stop functioning. So if you look overall at complications, a laparoscopic band has the lowest risk of complications, but it's also the least effective procedure and entails the insertion of a prosthetic or an artificial device into the patient. A gastric bypass is perhaps the most effective procedure in terms of weight loss, but it also carries the highest complication rate. In addition to the complications that are involved in any surgical procedure, since the stomach is divided, an anastomosis is made or a connection between the stomach and the small intestine, there's a risk of intestinal leakage and infection. Ulcers can develop where the stomach and small bowel are reconnected, and there is an increased risk of bowel obstruction long-term in these patients because their small intestine has been operated on, and there's risk for adhesions or scar tissue predisposing that patient to the development of a bowel obstruction. A gastric sleeve entails the same risks of leakage from the intestinal tract or infection the gastric bypass does because, like a gastric bypass, the stomach is divided and there's a risk of this leaking. However, in a gastric sleeve, the small intestine is not operated on. So the risk of bowel obstruction in the long term is significantly reduced from a gastric sleeve or a gastric bypass. If you look at effectiveness, the lap band is the least effective of these operations, and the gastric bypass is the most effective. Somewhere in between there is the gastric sleeve, although in terms of excessive weight loss and resolution of medical problems, the gastric sleeve is very close to a gastric bypass in terms of effectiveness. If you look at the complication rates for these procedures, it simply is the opposite of this. As the band is the simplest operation and the least effective, it also has the lowest, especially short-term complication rate, and the gastric bypass has the highest complication rate, with the gastric sleeve again being somewhere in between there. However, all of these procedures, whether it be a laparoscopic adjustable band, a gastric bypass, or what we call a gastric sleeve or a sleeve gastrectomy, the risk of complications from death and major problems from all of these procedures is still much lower than the risk of major problems or death from living your life morbidly obese. The type of follow-up required depends on the procedure performed. After a laparoscopic adjustable gastric band, the risk of nutritional deficiencies is lower. However, someone who has an adjustable band placed needs to follow up more frequently for adjustments in the band to change the size of the opening between the small and large gastric pouch. So while follow-up for nutritional problems is not as rigorous, we still see these patients at 2 weeks, 6 weeks, and then every 3 months as they're losing weight, and then every 6 months, and then eventually every year. However, the patient with the laparoscopic adjustable band needs to realize that perhaps as much as any bariatric procedure we do, their participation in follow-up is essential. Because unless they are keeping an eye on how the food's going down and how that band feels so they can have it adjusted as needed, the procedure will not be effective. The follow-up for a laparoscopic or open gastric bypass and a laparoscopic or open sleeve gastrectomy are essentially equivalent. Since part of the stomach is bypassed in both these procedures or removed in the sleeve, there's a higher risk of nutritional deficiencies. So patients after a sleeve gastrectomy or bypass are usually seen 2 weeks post-op, then approximately 6 weeks post-op. As they're rapidly losing weight, we follow nutritional parameters every 3 months to make sure they're not becoming malnourished. We expand that to 6 months as their weight loss slows, and then any patient, whether they've had a band or a gastric bypass or a sleeve gastrectomy, is considered our patient forever. They need to follow up at least yearly indefinitely to prevent nutritional complications from occurring, and so these things can be closely monitored for their health.